So I'm going to share with you about an evolving program called ROSE. It's an acronym for Removing Obstacles to Cervical Screening. And really, we know what we have to do in order to achieve the targets. Now, the data that we have seen or we have heard over the many years really come from high-income countries. And even when we talk about the switch in guidelines, what Dr. Bruni has shared, many of these are also from high-income countries. Really, if we were to achieve the elimination goals, we have to ensure that these effective strategies must extend to upper middle income and lower middle income countries. And so very much Rose was looking into the screening strategies when we were hit by the COVID pandemic. But I think that the lessons learned in developing Rose could be further adapted and could be, the agility of it can be extended. Now we know that the health systems between the different developed worlds and developing world is very different. And we can see from the stories that we have heard from before, we are learning lessons from Ebola. We do have approaches where we can mutually develop strategies for our local setting. And really organized screening is such a program that we can think about and learn from one another. So Rose was really a blank piece of paper in terms of a screening program. We used the principles of design thinking, whereby we took various evidence-based strategy using a human-centered approach to develop a program that was suitable for the Malaysian setting. Now, underpinning this is the monitoring and surveillance, and the program, as the global situation is evolving, we are also evolving, and so the program is agile. So these are the blank pieces of paper we were talking about. We go through the pathway of what a single woman would have to go through if she were to have a screening test. And even the mobile platform that we use were designed in such a way that it was simple and it could be used without taking much time. And this is really a story of collaboration where when we went down to the ground and we seeked the opinion and the experiences of the people offering screening tests. We interviewed many nurses, and we had many different experts coming to join the program. We had IT experts, we had banking experts, we had people who were very good with project and systems outside of medicine. So you can see that one of our biggest partners were, of course, our friends from Australia who brought in their tech expertise to guide us in our local setting. So the three components of ROSE are really this: self-sampling, HPV testing, and the use of digital and mobile platforms to link the women from the screening to tertiary care. So how it works quickly in the pilot setting in the clinic, I walked into a clinic, I registered myself, the nurse registered me onto her mobile phone. I got a message on my phone which verified that I gave the nurse the right number. She educated me on how to perform a self-sampling. I did it just behind those curtains, and it was processed, and I received a message the next day to say that my HPV test was negative. So you could use a point of care platform, or you could use a centralized laboratory strategy for testing. Now, the whole process takes approximately 9.5 minutes from the moment you check for eligibility up until the point of sample collection. What were the outcomes? 1 in 5 women were worried that they did not have the test done correctly because there were absence of discomfort. 4 out of 1,000 required nurse assistance, and about 2 in 100, particularly those who are postmenopausal, express some difficulty in self-sampling. Now, we have learned now that the education is particularly important in regards to the anatomy. Now, many women think that the self-sampling should be done because they have a vision that the vagina is a vertical organ. But now that we emphasize that the self-sampling should be done in an angled fashion, there's less discomfort reported. More importantly, in our pilot program, 90% of those with abnormal screening tests attended follow-up, and this is phenomenal. Two-thirds of the patients who received their results called up within the first day to schedule their appointment, and this was really encouraging. And we did a lot of qualitative work at colposcopy. We monitored how many calls it was required to engage with the women. And we also found out the stigma associated with it, and we are addressing that. That's for another day. So we've come up with standardized training materials with scripted instructions for the healthcare professionals, and this was done in the clinic setting. And the ROSE solution is very mobile. The setup is very simple. And we use the Copan flock swab, which can be kept in room temperature for 2 weeks, which allows us to go to various parts of the countries before it can be tested later on. The feedback was extremely encouraging. Many of those who did the self-sampling said that they would do it again, and they would encourage their friends to do it. With the success of that, pilot program ROSE became a program which was supported and very much adopted by the government. And I'm pleased to let you know that primary HPV screening is now adopted in Malaysia in a phased fashion. In fact, during the budget that was announced this week, the government has allocated some funding for HPV tests. And it was really quite a nice, quite an entertaining sight to see a male minister show at Parliament demonstrating how a self-swab can be done. So then we moved the clinic setting to the community, whereby volunteers, female volunteers within female leaders, then became the educators. They brought in the women, they taught them how to do self-sampling, and they could even register the women using the mobile platform. It was very simple. And the area in which they can do the self-sampling could be pop-up tents. And you see here on the left side, one of our Minister of Environment and Science used recycled banners as curtains, and you could go into these little made up changing rooms to have the self-sampling done. Then came COVID. The impact of COVID is huge, and where we are dealing with is just the aspect of health. And I think the far-reaching impact of COVID is yet to be felt. Significantly, in many countries, including ours, is the overstretching of healthcare facilities. And so the idea of self-care, particularly when it comes to cervical screening, becomes extremely relevant. And this is where we think that you could flip challenges to opportunities in the COVID era. We could move screening from tertiary care to primary care of the community. Diagnostic laboratories that were used or are being used for COVID can be used for HPV testing. And digital technology and public health measures used for contact tracing can be extended to follow up, particularly in the developing countries. And so we need to encourage and empower self-testing in these parts of the world. And I want to share with you a few projects. We came up with a Frontliners United Against Cervical Cancer program a couple of months ago, whereby we had the buy-in of the army and the police force. It was an amazing sight to see police officers educating, enrolling, and really encouraging their colleagues. So when there was a top-down order to get screened, we could go to various sites to get the police screens. In the community, we can perform screening using a physically distanced manner. You can see here we did screening in a school where the chairs were separated, and we timed the women coming in so that there were no huge crowds. Even our education was done in a physically distanced manner. So we had teams going out even to the rural area with the indigenous population to perform screening, and they could bring swabs back to a centralized lab. Colposcopy still continues on. In fact, we have made some diagnosis recently, which we could channel to treatment, but the PPE is quite a fuss actually to put on, and the fogging of the face mask is sometimes quite challenging. So I think as businesses transition and they think about the stages of recovery in terms of their industry, I think healthcare should also look at that, particularly screening. We need to address the challenges, we need to address supply chain, and we need to quickly get back to the agenda. This is my penultimate slide. I got this phrase from Balinson in the one of the latest HPV World newsletter. Dr. Xavier, you will be pleased to know. He says this: remember, systems make things work, not isolated technology. However, sometimes a technology comes along that encourages a system to be built around it, since it solves many unique problems. I think we have many opportunities here. Digitalization has taken off, telemedicine, the molecular laboratories have cropped up. We could perhaps use this to our advantage. Let's imagine the possibilities. Thank you very much.